Good evening, everyone. I thought I'd use few slides to make all of us understand the definition, the characteristic nature of this term called culture of safety. So I've searched for the most authentic definition, and I came across the IHI definition, the Institute for Healthcare Improvement. It's a global institute, and let's see what they have to talk about. People are not merely encouraged to work towards change. Here, people mean the family members also, patients as well as the family members. They take action when it is needed. That's the first characteristic of this culture. Inaction is not an option at all, especially when there are safety related issues. Eventually, pressure comes from all across the organization as well as from the patients. So, this is something very, very critical. In a culture of safety, there's no room for pointing fingers at others. You can't blame people. There are organizations where you find some people, they say safety is not my responsibility. I work for the finance department, so I'll file a report and I wash my hands off it. No, this is not acceptable in this culture. Leaders are expected to be visible in terms of their commitment to change. They have to demonstrate their attitude, otherwise their team members may not feel comfortable in expressing themselves. When they have issues to be raised, they may not express themselves. So you need to have an environment that encourages people to give feedback. And senior leaders do not just demonstrate, they have to also ensure they provide sufficient funds and resources for making things happen. Because it takes time. It's not that culture can be built over a period of few months. It takes as much as maybe a year to bring in this culture of safety. And in this particular features or the characteristic nature of culture of safety, we'll also conduct regular surveys. Within the organization, your staff members are encouraged to participate in regular surveys. Now, we all think once we get an accreditation, a lot is achieved. In fact, the entire organization works towards getting an accreditation. Months and maybe sometimes a year of work, they finally get an accreditation. And do you think that this is a clear mark of assurance for safety? The stamp of accreditation is not just a clear mark in terms of assuring safety. I'm sure many of you would have seen or familiar when a re-audit happens or when the initial audit happens, there's a lot of work happening. People come together as teams and they work for maybe months together, weeks together. There's a lot of homework they do just before the re-audit. Or just before an audit, a lot of work happens. Finally, you get the accreditation done, and what happens? There is an attitude sometimes to relax. Once you get, there's a lot of celebration. You advertise, you claim that we have a JCI accreditation, we have a NABH accreditation. Then slowly, the rigor with which you implement the protocols, it gets diluted, and people have a tendency to relax. And actually, the journey starts. At the point of time when you get the accreditation, the journey just starts. That's just the first milestone. It takes time. These are a couple of specific recommendations given by IHI to ensure that you continuously have a culture of safety in your organization. Conduct patient safety leadership walkarounds. I'm sure many of you would have come across senior people, CEOs sitting in air-conditioned rooms. They may not even get out. They think it's a job to be done by the juniors. No, this is a team effort involving the top person till the last person in the organization. Create a reporting system which is transparent, which encourages people to give feedback fearlessly. Designate a patient safety officer that allows clear accountability. It's because you need accountability. In fact, the whole organization is accountable, but once you designate a person, It becomes the responsibility of that person to ensure that this culture prevails in the organization. Reenact real adverse events from your hospital. We saw yesterday a couple of presentations. I saw from KIMS, the intensive care unit head, in a video clipping. He demonstrated a video clipping in terms of what they did. These are all useful tools to train your people internally. Involve patients in safety initiatives. Patients and patient relatives. It's clearly recommended. You will have certain patients who are coming to your hospital on a regular basis. You will have people, your family, you have to involve them in your processes. You can involve them even in the walkarounds. The recommendation from IHI says, please go ahead and recruit certain patients and their relatives in this process. Relay safety reports even when the shift happens. If there is an incident related to safety, if the shift is changing, you have to relay the matter. Appoint a safety champion in every unit, not only for the entire organization, even for smaller units, you need to have safety champions identified. Simulate possible adverse events and prevent them through protocols, through preventive protocols, and use that for training people. And conduct safety briefings on a regular basis, at least once a month. Create an adverse event response team, a rapid response team, whenever there is an issue. Now, strong recommendations. This is a slide which shows what AI can do, what technology can do, how it can become an enabler to rapidly and seamlessly establish culture of safety in hospitals. I am aware of certain AI tools which can help to stratify risk of individual clinical needs of patients. And this enables clinicians to rapidly access the risk of mortality and complications. I've recently come across a patient who went into a surgery. He was a cancer patient at the age of 89. He was suffering from colorectal cancer. When he was diagnosed, he was already in some 4th stage. And one day after the surgery, I think he was into ICU. Next day, he passed away. And his son was known to me. And I asked him, how did you allow this? Your dad was 89 years old. He was diagnosed of this stage of cancer. And he ended up spending something like 20, 25 lakhs of rupees. So it is possible to understand well in advance that there are complications going to happen, how to avoid that. AI-backed tools support evidence-based clinical decision-making to assess, stratify patients at an early stage and preemptively treat them. And you can avoid a lot of risk, like hospital-acquired pneumonia is clearly predictable with as accurate as 97% and as specific as, say, 98%. It can reduce avoidable harm. It can reduce mortality. It can reduce variation within surgical departments and other medical departments. And it will also help you to reduce clinical negligence claims and complaints. And there are measurements possible to measure even the skill sets of clinicians. There are clearly measurable parameters which are scientifically tested and proven based on the results and outcomes. Now, a lot of people talked about aviation safety, correlation between aviation safety and patient safety. It's a big subject. But anyway, I just came across this important, very interesting slide, which gives categorization of risk. A scheduled airline, a passenger airline where we all travel, it's supposed to be ultra safe, in fact. And European railroads and nuclear power, this is all supposed to be ultra safe. Now you look at where healthcare is appearing. Healthcare is appearing in a category which is called as dangerous, which means there is a possibility of 1 life in 1,000, is the ratio. Whereas in the ultra-safe categories, 1 out of 100,000, 1 out of a lakh, and 1 out of 1,000. So that's the magnitude with which it has been defined. Now, a simple comparison, all of you are aware of this, but I'm just sensitizing parallels to the aviation industry. A pilot is compared to a doctor. A co-pilot is compared to the junior doctors or the allied medical health professionals. And you have the crew resource management, the medical teams, and you have passengers and you have patients in a hospital. And what is common? Standardization is common. Accident investigation is common. We talked about black box, and confidential incident reporting is common in both the sectors. Now, there is one major difference, which you are all aware of this.
Basil will have to.
In aviation, over, this is the last slide. In aviation industry, the life of pilots and the crew is involved, along with passengers. That makes a huge difference. Okay, with this final slide, I'm concluding my introduction of this topic.
Yeah.
And over to Dr. Vijay.
I think you have very comprehensively given the entire spectrum of the safety in healthcare. Please just come over to your seat. I think a very important thing will be to understand that culture of safety in healthcare is very different than culture of safety in aviation or anything. So I would say, drawing comparison, I mean, I'll just tell you, I was recently traveling to United States and I had a ticket booked from Delhi to New York, JFK. My flight was landed instead of JFK at Bangalore, which is 1 hour before JFK, because the pilots had completed their 16 hours of their flying time and they will not extend that. So the flight is landed. I hope this can happen during an operation table where a surgeon can say, all right, boss, I have had my 4 hours of kind of a operating time, and now thank you very much, and I'll come back or somebody else will come and take it over. So I'm saying that this, and in fact, when we compare this aviation into with the healthcare, it is so totally different that I feel that if they were to fly these planes into a healthcare kind of a issue, they will crash every single day, much more than probably what we are doing. Yes. So anyway, I'm saying that this issue of healthcare safety and lot of things can be there to pick us that what are the problems. Now, for example, in my opinion, most hospitals, we don't require an artificial intelligence to understand that most hospitals are vulnerable during the night hours. You know, most hospitals work on solar energy. You come after the routine hours, and the hospitals are vulnerable where the least qualified staff, inadequate staff, sleepy staff is available. And it is a recipe for disaster. The issue is this, that if the hospitals understand that, I'm sure most of them understand. Let me ask the youngest of the colleague here, Dr. Gaurav Agarwal, as to, do you relate to this particular scenario of, let's say, vulnerability of the, let's say, the safety issues of hospitals during night time, and what do you think that you can do to handle that?
So thank you, Dr. Vijay, and thank you for inviting me at this Cahocon 2022. It's been such an honor and pleasure to be here. So Caho has always talked about patient safety, continuous quality improvement, and another thing has been, which has been Caho's main proponent, has been the use of technology in healthcare operations. And I am a very vocal ambassador of, when you get technology into hospital operations, you simplify hospital operations, you make hospital operations safer, and you improve the efficiency. I'll give you an example, sir. It is not just about the night operations, or it is not about the morning operations. We were having a very small panel yesterday. So 3 months back, we are at Max. We have fairly good hospital information systems. We have lab management systems, radiology systems, PACS and everything. So we realized there are two problems in the basic setup. The first is the orders are written by the doctors. The nurses are, spending most of the time transcribing these orders and indenting it, and there is a lot of inefficiencies and compromise on that. And the second part is, all these medicines, when they are delivered, we don't know were they given to the patient on time, how many missed doses were there, whether the doses were given more or there were duplicate orders given. So what we did is incorporated technology into hospital operations. So we did our barcoded medication administration system in the integrated it with the EHR. So what we did is every patient on his wrist has a
Gaurav, you are ducking my question.
no
Tell
no.
me, what are you doing to prevent problems at night?
So
Uh,
I'm coming to that, sir. So
Okay.
the major problem at night will come to patient safety is medication administration. So I am saying first part is when you input technology into the medication administration process, because after 8 p.m. there are so many night admissions which are happening. How are you sure that all these night admissions were given the medicines on time? So as simple as that, integrating it with the EHR, a patient is having barcode, and I'm saying the barcode is common for all his interfaces, whether it is lab, radiology, medication, or hospital operations. So what I'm trying to say is, if the orders are directly written into the system and the orders are given to the pharmacy sends the medicines to the floors, and the nurses is scanning the barcode, you are automatically reducing the medication errors and you are improving the safety. The other point which I want to make, just to add to that, is all the hospitals have either EHR, some has RIS, some has LIMS. What I'm saying is, as we evolve in hospital operations, we have to get it integrated into one common platform. That is where technology will help to simplify hospital operations and bring the cost down. If you have these one platforms, it is like initially you were driving a car with 2 airbags, and many people will say we don't need 6 airbags. But now either the regulations will force you to get 6 airbags car, or the passenger himself is selecting a 6 airbags car. That is what the point is. All of us, to improve the safety, will have to get good technology solutions to improve the overall hospital operations and integrate them into one common platform. Earlier it was one basic HIS. I feel all these 6-7 modules have to be integrated into one common platform. And that is where technology companies have to work. It's a market. It can be secondary care hospitals or a tertiary care hospital, or as strong as corporate hospitals like
No,
ours.
great. I think you have made a very strong point of trying to use technology to introduce safety even during the off-time hours. Dr. Padak, would you like to add anything that you think that can be made to say that how the hospital can be safer during night time? Just we are looking at short kind of inputs as to what steps, if you think you have taken in your hospital, do you think that is a problem?
Thank you, Dr. Agarwal, for this great opportunity. Um, what we have done is the managerial staff, usually managerial staff are there in the night, only one person. So we have seen that this possibility is there because in the night, anything could happen. But for mission hospitals, one thing you should understand is most of the priest, the CEO and associate directors are there inside the hospital. We are 24/7 available. Apart from that, the managerial staff will be there, now 3 in numbers, to oversee. Apart from the nursing manager, the uh, the other related utility manager and also the medical person who is in charge will also be there, so that we could avoid a situation where a hasty decision or a risk is a possible risk is avoided.
Yeah, thank you. I'd like to thank Cahocon and especially Dr. Saudullah and Dr. Lallu Joseph for inviting me. Um, from the Indian perspective and practical point of view, to the question, two things. One, I think there was a lot of discussion taken up how the flight safety as well as the hospital safety. Just put it in number, it is 1 in 3 million and 1 in 300. That's the number which we are talking about, so it's a huge difference. So coming to the question of night safety, all of us are working in a hospital and we know how the night operations in our hospital. We don't have the full strength of doctors. We don't have the full strength of second line doctors like residents and medical officers. Only the ER doctor takes care of the hospital. Rest, the ratio in which the hospital functions in the night, all of us are very well aware, like if it is 1:1 or 1:2 or 1:5, none of this ratio is applied in the night. So naturally, the patients are at risk. That's the actual practical situation in which we are actually handling it. But in practical sense, if you ask me like whether is it possible to have the same ratio continue in the night also. It is practically not possible, or maybe economically may not be viable, but we are putting the patients at risk. And I think there may be some kind of systems that may be available to ensure the safety of the patients. To answer your questions, that's the practical sense in which the hospitals are running. And especially during the last 2 years, especially, we all know that we underwent the pandemic experience. We are still undergoing. The amount of the load that has been taken up by especially by the nursing community is huge. And the amount of the allocations, or the kind of allocations what they used to have, everything, all those rules was kept in air, and none of those rules were put in practice. And last 2 years, and 1:1 had gone into 1:3, 1:5 has gone into 1:8. So naturally, a person, as a person, she or he has got a capacity to handle it. And with this kind of number, naturally, the patients are at risk.
Thank you, Cahocon, for giving us the to come and attend this. I would like to come straight to the point. Is that appropriate staffing has to be there. So hospital runs 24/7. Dr. Vijay rightly mentioned the soap point that is now coming, staring at the health sector is we are running on solar energy. That is very relevant. I think so. We are not doing justice to the patients. So every department where they get acute care patients, likely at night, the department people should be involved in that, of putting appropriate staffing there. I'll just give an example. Way back in 2004, Dr. Vijay was the director of the hospital. I joined as the director of critical care and anesthesia. At 24/7, a DM cardiologist was present in the CCU, in the hospital. What happened? Within 6 months, Max Sake took off by like no one's business, because they knew that any time of the day and night you come, your heart will be taken care. A neurologist, neurosurgeon was always there, 24/7 when the West Block started. So what happens if you take care of the heart and the brain? Dil aur dimag rules the body. So that's what was important. He was asking that, which I think so needs to be addressed. And the other thing is that we always tend to forget the nursing. Again, the nursing head must look at what is the staffing that they're looking at night. So to put appropriate people there. And as my colleague rightly mentioned about medical officer on duty or whatever should be there, who look at the administrative part all around. So I summarize it as appropriate staffing in consultation with the doctors, appropriate nursing staffing with the consent, with the cooperation and of the senior nurses there. That's the only way we can assure quality care.
I want to add to what my colleagues have said. There's a culture of empowerment. It's so important in the night. You may not have all senior people in the hospital in the night, but you may have only junior people. But if they have given the freedom to decide, if they have given the fearlessness in their mind, I don't know, some people, they wouldn't even call their senior consultant because they feel for a trivial reason they are calling him, or that person might shout it back. So the culture of empowerment is so important when you're talking about service in the night.
Well, sir, I agree that some degree of empowerment, but let me say from the point of view of, I would say, carry home message, which I would like to give during my time, what I did was, number one, administratively, before the night shift starts, I think the administration should have a list of people who are vulnerable in your institution. They may be clinically unstable, they may be emotionally unstable, they may be financially unstable. Whatever the reasons of that instability, you should mark out that these are my 15 or 20 patients who may become a problem during night. And therefore, so all your night managers, etc., can be asked to give an extra round, an extra care of these people, so that the idea is to prevent also a problem. So the idea is, yes, if there is a problem, then naturally the people who are there will take decision, empowered or not. Second thing is that these people should be empowered more to call the senior person's help by being vociferous that, sir, I need you. Don't kind of sit around on the hedge, okay, all right, I'm waiting for half an hour or something. If you really feel, yes, that you are needed, it should be said, yes, that you are needed, please do come. The other problem is, which is I am seeing particularly in our country, and that is the reluctance of the senior people to be present during night, even as a routine duty. This is not there even in a country like United States. There is even a senior of mine, he is now 78 years, director of neonatology at Louisiana. He still does shift night duties, sir. He's the director of that unit. But he says, I cannot think that how can I ask my juniors to do the night duty when I am not doing. So that culture, unfortunately, is not there, and I don't think that we will be able to change that very time soon. Uh, there are huge other aspects of, I would say, safety. Unfortunately, I am being asked to wrap up this session because of the paucity of time. So what I will do is that I think we will make, sir, our group. Yes, yes, Dr. Vishnu. No, all of you can make another one minute contribution. And
I think the safety is not the responsibility of the safety officer, safety manager, quality manager of the hospital. We must get the clinician group, the nursing group involved in it. I think that is where the catch is. We are just, because if you don't involve them, you cannot implement quality. Because they are the makers, the checkers are the quality managers, and most important is the nursing. Very hospitals which have done well are the ones which have involved the nursing well, explained why this is done, that why should be explained. If you take care of the whys, the outcomes will be good.
Please, your 1 minute for developing culture of safety in your organization.
So, as far as the safety is concerned, there are two important things. One is our environmental factors, process, and the structure. That is actually structured in such a way that it is ensuring the safety of the patient. The next important is everything is related to the attitude. And if the attitude is perfect and the safety is ensured, everyone in the hospital, starting from security to the consultant, should be committed for the safety of the patient.
I have 3 points.
If in a mission hospital like ours, the safety is not only the concern of the safety officer. Actually, I would say it is the concern of everybody, even the patient bystander. So, because it has to be a concerted effort of everyone involved, because we rely not only on our nurses, the paramedics, but even the help of the family members who are bystanders or responsible people who are there with the patient. So that is that culture is inculcated, and it is everybody's concern that we uphold the patient safety at every moment, whether it is in the middle of the night or in the daytime, wherever. And the safety audits, the rounds, all those things, the empowerment, all those things are there as part of our culture. So it is not a one-day event, it is a routine, and that's how we have made this possible.
Thank you. In today's date, we have to even have safety of our staff besides the safety of the patient. So, Gaurav.
Yeah, so just to conclude, I think as I see it, again, safety has to be made more and more objective. Whether so at night, what time the initial assessments are done. If you get those reports, what time the medicines were given, you can get those reports from the systems. The more and more you make the systems more transparent, the more and more reports you can get it generated from good hospital information systems, the more and more transactions you can make more and more objective, the safety will become transparent, and you will be able to audit it on a daily basis, on a live basis, and you can see yesterday night how many admissions from ER were actually seen by the doctors on time, and the medicines were given on time, or any other orders were given on time. So, and you can check those compliances. So my take would be making it objective and making it more transparent through the use of technology, good software, and good hospital information systems.
So thank you very much, ladies and gentlemen. I think we'll have to just
3 points which I want to suggest. One is proactiveness in everything that we do at every point of service. Proactiveness. Anticipate the problem in advance. Don't react to that issue. Second thing is technology. Whoever can afford, you should understand technology and use it to the hilt. That's the way, but we are talking about the way forward. Without technology, we cannot think of healthcare progress at all. And the third thing is the culture of empowerment. You know, we are in a platform of service. Everybody is equal in a hospital. A platform of service equalizes people. This should be remembered, and everybody should be encouraged to,